measure the quality initiative to improve the standardization of the care from the related to international. Professor Wilson, please.
Thank you. So we are going to shift slightly our focus from the broader ACS universe to basically focusing on STEMI and STEMI systems of care. And we'll give our U.S. experience and scale to international. I have no disclosures. So this appeared in the New York Times a few years ago, saying the death rate from coronary heart disease has dropped 38% in the previous decade. And they reference a sea change in treating heart attacks, where hospitals are partnering with each other with systems of care to drop reperfusion time. And even more recent, this summer, from the ACC NCDR, U.S. hospitals set record for fast heart attack care, with more than 93% of patients now having their arteries opened within 90 minutes of arrival. And I think we're all familiar with the time is muscle mantra, in which really in the first 4 to 6 hours, the focus is myocardial salvage. And then beyond that, the goal is time-independent, open infarct-related artery and the benefits that it has long-term. So this really was all started with the meta-analysis from Keeley 10 years ago, or 15 years ago now, in which, looking in hospitals when patients arrived with STEMI, if you compared their results with primary PCI versus fibrinolytic or thrombolytic therapy, in every metric, PCI in blue-green here was superior outcomes compared to thrombolytic therapy, with 95% TIMI-free flow, less re-occlusion, 2% survival benefit over thrombolytic therapy with PCI, and eliminated the 1% intracranial hemorrhage. Now, if you take that on the road, these 6 studies more than a decade ago, primarily from Europe and 1 from America, and then the total meta-analysis, you can see here on the left side that the relative risk was greatly reduced for the combined endpoints of death, reinfarction, and stroke with primary PCI after transfer versus thrombolytic therapy, so-called rip and ship type of strategy. So how does that compare in my country, in the U.S., where 42% of patients are, or less than half, are the PCI hospital as their closest facility, whereas nearly 80% are within 60 minutes of any hospital. You can see the population centers where the PCI is in this green popcorn pattern. And try and keep that in mind as we look at STEMI coverage a little bit later on in this talk in the U.S. since that time in 2002. And then 6 key strategies from the Yale group that were, again, from the NCDR database of hospital interventions that reduced door-to-balloon time. And those were having the ED physician activate the cath lab reduced by an average of 8.2 minutes, providing real-time feedback to the emergency department and cath lab staff, another 8.6 minutes, using a single call system to activate the STEMI process, reduced it by 13.8 minutes average. Staffing a full-time attending cardiologist on site, difficult to do, but another 15 minutes if that's available. Having EMS diagnosed, usually with pre-hospital ECG STEMI, en route, reduced the average time to reperfusion by 15 minutes. And then requiring cath lab staff to arrive within 20 minutes, another 20-minute reduction in door-to-balloon times. And from our own program, the North Carolina RACE program, we showed that bypassing the emergency department, going directly to the cath lab, significantly reduced door-to-balloon time. And if you take that a little further and bypass non-PCI hospitals, you can see from Dieter's study or report in the Netherlands, the top green line, both short and long-term survival after 1 year was much better if you bypassed non-PCI hospitals and went directly for primary PCI. If you are going to a non-PCI hospital, it also makes a difference how much time you spend in the emergency department there, the so-called door in, door out, or EDO time. If you spend less than 30 minutes in that non-PCI hospital before transfer, your mortality is about 3%. If you spend more than 90 minutes, it's close to 10%. So all this was great with door-to-balloon times. We're going to have an elegant talk from Dr. Brush right after me, which really shows how the whole door-to-balloon project was really an anchor for starting quality initiatives in STEMI care. But this was sort of a little bit of a detractor a few years ago, the Benny study, in which he showed that even though door-to-balloon times in the U.S. had come down greatly in the last half of the last decade, it didn't appear to change the overall 30-day mortality, still hovering at around 10%. But if you looked at it further and actually adjusted for those patients who had cardiac arrest, you can see that after 2008, mortality is actually coming down here and became significant after 2011 with reducing door-to-balloon times. So since that time, and you can see now both in the ESC guidelines and in hopefully the ACC guidelines in the next few months, the door-to-balloon time is no longer the measure to watch, but really more appropriately in the big sphere will be first medical contact to device time. So just to summarize at this point, then the top quality initiatives that I think we've learned over the last 20 years are the ones that I've just spoken to, including the thymus muscle, PCI greater than thrombolytic therapy in terms of outcomes. Local hospital strategies can help reduce reperfusion time. Pre-hospital ECG is key. Single call activating the cath lab from any location is also an important point. Bypassing emergency departments and bypassing non-PCI hospitals. When they do have to go to a non-PCI hospital, they need to try and get out of there within 30 minutes. And from the latest complete ACC guidelines of 2013, regional systems of STEMI care are a 1B recommendation that all communities should create and maintain a regional system of STEMI care that includes assessment and continuous quality improvement of the emergency medical service and the hospital-based activities. So how are we doing? So this was a survey we did across the U.S. of the chapters of the states this summer, and we asked the leaders of those chapters, the governors, so to speak, of the ACC, how many of them and how many of the folks in their state were involved in STEMI systems of care. And over three-quarters, 78%, said that they were involved themselves personally with a regional STEMI reperfusion program, and that 83% had fully functional STEMI systems within their states in the U.S., the 50 states of the U.S. So how good were they in predicting the penetrance of STEMI systems of care in the U.S.? This is actually from another metric, which is the Mission Lifeline, and you can see now in this map 83% coverage across the U.S. in blue of mature STEMI systems of care. And if you remember that popcorn green map I showed you from about 15 years ago, you can see that we've come a long way in coverage of STEMI systems within the U.S. And then the latest couple of projects that we've been involved in are the STEMI Accelerator programs, in which we're looking at metro-regional areas in the U.S., 16 metro areas covering over 30 million lives, and that was conducted over about an 18-month period from 2012 to 2014 with improvements in their systems of care. And you can see that, for one thing, the message is out there. The symptom onset and first medical contact averaged 47 minutes. We had about half of those nearly 24,000 patients came by ambulance, and then the other half were split between those that came by private car or were transferred in from an outside hospital. And if we looked at the top 5 out of those 16 regions who were achieving guideline goals for their reperfusion, you can see that they also increased over that 18-month period in a dramatic way. And if you compare that to the database in red, you can see that there was a drop in mortality, although not significant. It still showed a marked trend. So that began the second phase to really try and reach that brass ring of showing a difference in mortality, saving more lives by these STEMI systems of care in the U.S. And you can see the Accelerator 1 groups are in red, and the gold groups, over 600 hospitals in 12 new regions, are in gold. And those results are going to be presented at late-breaking clinical trials at the AHA on November 14th this year in Anaheim, California. And basically, the goal is to have the first EMS medical contact or non-PCI hospital door to device of 90 or 120 minutes respectively for more than 75% of the patients. And then, of course, to have those teams and leadership in place and monitor and maintain that throughout the 18-month period, and hopefully to achieve, again, difference in survival. So those results are embargoed, but they are going to be part of the late-breaking clinical trials, and I invite you to tune in another month. So that's great. And so what can we do in other countries? How can we scale this internationally? And one is to think about taking that same program and taking those same pillars. Stage one, establishing a system of care, whatever that be, wherever that is, and then develop a transfer system, and then finally have full integration of the system between thrombolytic therapy and PCI and transfer for definitive care. We're going to spend some time talking about that type of strategy. We actually have some grants, including some major corporate input for a $14 million heart rescue global project, which is going to see if there is an international effort to improve survival from acute cardiovascular disease through these implementations of these systems of care. So Dr. Liu spoke very well and also thoroughly about the findings from the PEACE study, and I'll just highlight the part that she spoke to regarding STEMI. And that was a great study and report of a period of time, snapshots in 2001, 2006, and then in 2011, to look at the trends in reperfusion care as well as the treatments that these patients were getting, as she outlined. And she actually showed this slide that showed that there was an increasing rate of STEMI admissions up to 15% per 100,000 population from 2001 to 2011, with nearly 200,000 STEMIs, hospital admissions, by 2011, reported in that study. And I think the key thing that she showed as far as this talk is concerned was that despite these different time frames, there was about a 50% reperfusion rate in 2001 and again in 2011. It was an improvement that there was about half of those with PCI versus thrombolytic therapy, but overall still there's nearly a 50% group that were not getting any therapy, and there are multiple reasons for that. But also, as the panel pointed out, now the new ACS project has made a difference in the last couple of years. And the other point was that she also showed that during that period, actually the comorbidities or the complexity of these patients also increased during that time. So as far as STEMI care, the hospital rates and absolute admissions for STEMI are rising in China. Prevalence of comorbidities have increased, as she pointed out. And then while quality of care has improved, still, as in many countries, gaps exist. And unfortunately, in-hospital mortality had not changed during that time period. What about India? Another 1.3 billion people, where primary PCI is the treatment for less than 10% of STEMIs. And we know this from both the Kerala and the CREATE registries, as well as the STEMI India document published a couple of years ago. Although there are projects going on in India now for developing systems of care, including the 10 STEMI project, in which not only are they trying to link systems of care, they're also employing technology with telemedicine, linking the academic centers with the emergency medical providers in rural communities. So traffic also can be congested in India as in many countries, and this project in Bangalore started earlier this year, which nurses on scooters are used to reach patients through heavy traffic and then develop or treat with thrombolytic therapy. Other countries, as we know, also have incredible traffic congestion, and so it's pretty difficult to count, time of first medical contact reperfusion in these areas where it's so difficult to transport patients. And also we all have kind of the reverse system happening in some highly populated areas like Sao Paulo and Singapore, where patients are actually brought within 10 miles of the metro hospital, and then if the resources are available on both ends, are actually flown to the helicopter rooftops to get definitive care. So in this program of trying to integrate care internationally, the final STEMI frontier, can we improve on primary PCI with concomitant thrombolytic therapy? And should all fibrinolytic or thrombolytic patients go to PCI? And should only the so-called thrombolytic or fibrolytic failures get PCI, the so-called rescue approach? So there have been several studies along the way, including the Transfer AMI project in Canada, the FAST MI program in France, and I think this is really the landmark study. Paul Armstrong and our Canadian colleagues, and also going internationally in this thrombolysis for primary PCI and ST segment elevation myocardial infarction was published a couple of years ago. And basically, this was a unique program in which they took STEMI patients who had been less than 3 hours from onset of symptoms, and then if they did not get primary PCI within 60 minutes, then they were randomized to a strategy of pharmacoinvasive, in which they got TNK, or they got primary PCI. They could be done within 60 minutes, or they were randomized to get primary PCI and no thrombolytic. And then later on, because of bleeding in the elderly, they actually adjusted the protocol so that those over 75 years of age got half dose TNK with thrombolytic therapy. Plus, they got standard treatments like DAPT and enoxaparin, and then ultimately also came to a cath lab center and either got rescued or early cath and PCI indicated in 6 to 24 hours. So the primary endpoint was the composite of all-cause death, shock, heart failure, or reinfarction up to 30 days. So how did they do? So here what you can see is what you expect. The thrombolytic group actually had initial 60% reperfusion, as we've known historically in the past. And that was the pharmacoinvasive group, and the primary PCI group was not initially reperfusion, but then after PCI, both of them had about the same, greater than 90% reperfusion rate. So how did they do on these all-cause endpoints? And what you can see is there was no difference in the pharmacoinvasive group with nearly 1,000 patients versus the primary PCI group. No really difference in outcomes up to 30 days. However, initially, as I pointed out, there was increased intracranial hemorrhage in the pharmacoinvasive group. But after they amended that was about after 25% of the patients had gone through the program. After they amended that, there was no change in bleeding between the two treatments. And that was also true for major and minor bleeding. So from that, what we can presume is that transfer for primary PCI is better, as we've shown, than pharmacoinvasive therapy, which is better than thrombolytic therapy alone. So pharmacoinvasive PCI with thrombolysis may be the second best option, but if primary PCI is not possible within a reasonable length of time, 2 hours, then optimize your local STEMI network so that you don't need this second best option. And so that's impacted just the latest ESC guidelines, and I mentioned the ACC guidelines should be out in a few more months. But the major points are that now the time limits for routine opening of an infarct-related artery is class 1 for 0 to 12 hours, and it's a class 2A for 12 to 48 hours. And then time to angiography after thrombolytic therapy is now early, 2 to 24 hours in either case. And some other important guideline recommendations that we're seeing prevalent in practice, of course, are the radial approach, the preference of drug-eluting stents over bare metal stents, consideration for early revascularization, not necessarily before discharge, but within a month, less use of bivalvulitic in favor of heparin-based antithrombotic, except if it's from the femoral approach. And now thromboaspiration of clots is a class 3 possible harm recommendation. And then, importantly, particularly for this talk, that half-dose thrombolytics are recommended in patients over 75 years of age to avoid intracranial hemorrhage. So this is a nice sort of red light, green light sort of chart of those factors that I just mentioned that are in those guidelines, and particularly, again, for the patients that are over 75, the half-dose TNK is recommended if there's a pharmacoinvasive approach. This sort of outlines how one might look not only in the U.S., but in China, India, and across the world in terms of reperfusion strategy internationally. You make the STEMI diagnosis as early as possible. That's actually been considered the time zero or first medical contact. And if they can go to a primary PCI capable center in an early time, preferably within 60 minutes, then they should get primary PCI. Obviously, that's a very difficult hurdle in many places logistically. So if that's not possible within 120 minutes, then they should get immediate thrombolytic therapy. And if successful, go ahead and be transferred then to a PCI center for a definitive therapy. And if it's not successful, go ahead and get immediate rescue PCI. So that's pretty much it, how we could cover this internationally and may become the new platform for STEMI care. So thank you very much.